Welcome everyone who might begin. Just checking, Brendan, are you okay to begin?
Absolutely.
Okay. So, welcome everyone. It's Jeremy McAnulty and co-facilitating is Brendan.
Hi, Brendan Cutmore.
So, thanks very much everyone for joining us on this discussion exercise on COVID-19 in regional Aboriginal communities. I'll hand over to Brendan in a moment, but I'm Director of Health Protection and the COVID branch at the moment, and participating today. We won't do a formal roll call of all people listening in, but we've got public health units, Aboriginal health units from LHDs, Aboriginal controlled community health services and AH and MRC, amongst others, joining us. So welcome everyone. And Brendan, over to you.
Perfect. So good afternoon now, everybody. I'm Brendan Cutmore, so Director of Aboriginal Health and Wellbeing with the Western New South Wales Local Health District. I'm a Kamilaroi man from Tamworth, New South Wales, and I also get the privilege of giving the acknowledgement to country for this session. So I'd just like to acknowledge, whilst I've got the floor, that we're meeting on Aboriginal land, wherever we're dialing in from today. I'd like to thank you all for joining us for this important conversation for our Aboriginal communities moving forward.
Thanks very much, Brendan. So the way it's going to work is we've got various people playing roles, and Brendan and I will take Bronnie is going to read out the scenario, and Brendan and I are then going to provide questions to some of the players. So and we'll need to finish, and then at the end, Steve and Jamie are going to be able to provide a bit of a debrief. So we need to just be cautious of our time. So on the next slide, just talking about the aims, is to understand our various roles in responding to COVID, share how we work, understand how we implement culturally safe public health responses, and strengthen the coordination between our various sectors in the outbreak management, particularly in an Aboriginal community. And it's not a test, and so the idea is let's enjoy kind of the discussion and the learning we have. And just remember to mute off when you're not speaking. Don't answer the phone because that can create some music. So today's actually part A of an exercise. This session's focusing on the regional setting. We won't be able to have general questions apart from people who are players from the audience today, but will be an opportunity for local discussion over the next few weeks when this part B is held. So part B is where public health units facilitate in partnership with Aboriginal health units and community controlled health services in local areas. And so that's a session where we have local discussion. And today's scenario is completely fictional, and we'd like you to consider how you'd approach it if there was a case in your local community. And as I mentioned earlier, we've asked Steve Corbett from Western Sydney LHD and Jamie Newman, who's CEO of the Orange AMS, to lead us through a quick debrief at the end and to summarise and bring together some of the learnings. So Brendan, over to you.
Perfect. So today we're going to be joined by an esteemed panel of people from across our state. I won't go through the full introduction of all the people who are on the panel, but I will run through just so that people are aware who we've got representing us. So obviously Jeremy and I are facilitating the session, representing the Centre for Aboriginal Health, the amazing Jerry Wilson Matanga, through the AHMRC, Robert Skeen. So welcome on board, Robert.
Morning, everyone.
Through our COVID-19 Public Health Response Branch, we have Christine Selvey and Jenny Musto, and we'll also be joined by both Roy and Mary Kay from playing the laboratory liaison role through this. Our public health unit today that will be a part of the session will be from Hunter, New England, and I can see the smiling faces of our two people who are very familiar to me. In both Kirsty and Kylie. They're joined by Kat out there. Our Aboriginal health unit, Aboriginal Health Unit Director, coming all the way from Mid-North Coast, Robin Martin. Our AMS today that's representing us through this panel discussion will be the amazing Wildwood Aboriginal Medical Service, led by Christine Corby, supported by Keith Gleeson as the GP, Whitney Skewthorpe and Wayne Beadle, chronic disease managers. Our clinic manager will be Philip Dowse, and clinic RN Sonia Blair. And debrief at the end, as described by Jeremy, will be from Stephen Corbett from Western Sydney LHD. I can see Steve online, and also Jamie Newman, our CEO of Orange Aboriginal Medical Service out here in the West region as well. So thank you so much to the panel for their time today, and we really look forward to your insights through this session. I do want to reiterate what Jeremy had said, and that's that we just love for you to relax through this, not feel like this is a massive test. But obviously we're fascinated by the outcomes of this conversation. I think the last part that I would acknowledge before we move on to the next part of the session is that this fits in and deserves acknowledgement of the role that's been played so far by New South Wales Health and so many of our public health and Aboriginal health units right across the state through the pandemic. I do want to congratulate the system on the effort that has been made in supporting our Aboriginal communities so far, and let's hope that we learn from this session today as well, moving forward.
Great, thanks very much, Brendan. So I'm going to hand over to our narrator today, Bronnie Anderson-Smith, who's got her fine acting voice on.
I'll do my best. All right. Thanks, Jeremy and Brendan. So our scenario opens with Renee Johnson, a 22-year-old Aboriginal student who lives in a regional community, who wakes up with a sore throat on a Thursday. By Friday lunchtime, she has a runny nose, and her Auntie Joyce sagely advises her to go and visit the local AMS. Renee has a telehealth consultation first, and she tells Dr. Lee, her GP there, that she's had a sore throat since Thursday morning and a runny nose. As these are COVID-19 symptoms, Dr. Lee recommends that Renee attends the AMS in person for a COVID-19 test. On arrival, her temperature is taken and it's 38 degrees, and Dr. Lee tests her for COVID-19 and influenza in an outdoor clinic.
Thanks, Bronnie. So first questions are to our lab liaison, Roy and Mary Kay. What testing options are there in regional and remote areas in New South Wales?
Yeah, so there's two main categories. So one is through the public COVID clinics. And so most of the hospitals have a COVID clinic available where people can rock up, and there'll be a clinician there to do the assessment, and then staff there that can collect the samples. And the other way through the private laboratories. And through the private laboratories, there's various avenues. There are the Commonwealth-funded COVID respiratory clinics, which are run by GPs or medical centres. And so people can arrange an appointment through there. People can also, in regional areas, do a telehealth consultation with their GPs and then present to a private laboratories collection centre. So they need to book to have those collections done, or they can go through the AMS. So the AMS has an arrangement with the private laboratory to organise the testing. They're happy to collect at the AMS, and they can send it on to their private pathology lab for testing.
Great, thanks, Roy. And is testing prioritised for Aboriginal people?
In the New South Wales Health COVID clinics, yes, Aboriginal people have priority testing. So if they identify as an Aboriginal person, then the test can be prioritised. I should also mention that New South Wales Health has in 37 facilities gene expert platforms which can do rapid testing, so have results available after collection in about an hour.
And when you prioritise, what does that mean? Is it faster turnaround? What sort of turnaround might you expect?
Yeah, so there's still delays with getting the specimen after collection to the testing laboratory. Most of the, in New South Wales Health public laboratories, most of the testing is done in laboratories in the metropolitan areas. However, there is increasing capacity in the regional areas, for example, Wagga Wagga, and in Bega and Dubbo, they are providing testing in those laboratories, and so once the specimen gets to the laboratory, then they can prioritise and put them onto the next run and have the results quite quickly.
So for a person getting a test say on the weekend or during the week, what would be the time from getting a test until getting your result? Roughly?
That varies. So weekends transport is a bit limited. So getting the specimen from a site, from a GP clinic, for example, to the testing laboratory, it could take a while on the weekends because of the limited transport options. They may only have perhaps one run, courier run from a GP to the laboratory once a day, and so once the laboratory gets it, may be quite late in the evening, and so won't be tested until the next day.
So you might be looking at a day or two.
Okay. Yeah. Once the lab gets the specimen, then it's another day for the results. So it could be 2 days or possibly 3 days for the results, especially over the weekends.
And in more remote areas.
That's right. Yes.
So I might just go to the Walgett AMS team. What advice would you be giving Renee to follow at this point while she's waiting her test result?
I suppose the recommended advice that we give all and also with Renee is obviously self-isolation for that 14 days and advising them and obviously reassuring them that we will contact them ASAP when those results get through.
Okay, what about other people in her household like Auntie Joyce?
I think the best that we can do, especially if we live in, if we've got big family members living in the one house, then we'll actually talk about the basic hand hygiene, cough etiquette and things like that. If you can, because it's very, very difficult if there's a lot of people in the one space. So, you know, if you can isolate within at least 1 metre of each other, 1.5, then that's recommended. If you can't, then it's all about hand hygiene and cough etiquette at the end of the day.
Okay, Bronnie.
All right, so we were very fortunate this time. It only took 1 day for the lab results to come back, but the test is positive for COVID-19.
Oh, sorry, what was that?
Sorry, I was just, for our next slide, the test result has come back 1 day later, and the result is positive for COVID-19. So over to Brendan.
Perfect. Well, we might go back to our laboratory liaison team, Roy and Mary Kay. So our first question is, so who does the lab inform about a COVID-19 positive test result?
Yeah, so the testing laboratories have a requirement to inform the referring clinician. So if so the AMS would be using a private pathology provider, and so they would inform the AMS of the result as soon as they know the result of the test. And the laboratory will also inform our Public Health Emergency Operations Centre of a positive result, and possibly if they have good arrangements with the local public health unit, inform the public health unit as well. So eventually the public health unit who looks after Renee will be informed either through the laboratory or through the FIOC. And sometimes the AMS, I think the AMS also has good relationships with the local public health unit, so eventually everybody who needs to know will be informed of the result.
Perfect. That's a wonderful segue into the next question, which is what support is available for our Aboriginal Medical Services to interpret lab results? So the FIOC is available. Myself and Mary Kay is able to talk about the results. The laboratory is also available, so if there are any questions about the result, there are clinical microbiologists in the laboratories who can explain the result and what the test results mean. Perfect, thank you. I'm going to go back to our team at Walgett AMS now for a question to the clinical team. So how is Renee notified of the result?
So Renee will be notified by phone or SMS. If she's unavailable, then we have at hand our Aboriginal health practitioners who will actually go out to Renee's home.
Wonderful, thank you. I think at this point in time it's important to hear from our Public Health Unit Controller. So to Kat, you've just been notified of this case. What are your immediate priorities?
Thanks, Brendan. Certainly we'd be liaising with our lab colleagues. So the priority when we have a confirmed case is to interview the case and to get that case and their close contacts into isolation. But before we do that, we'd probably be looking to confirm the diagnosis. So, this is a swab, but, some cases we get through notified as serology, and there's a bit of looking into that needs to happen. As Roy said, this might have been through a private laboratory, and so we'd be checking in with the private lab. We'd be potentially asking about, how strongly positive that swab was. So a few things around confirming the diagnosis. Then we would normally liaise with the person's medical practitioner, the person that ordered the test, to find out what's been communicated with the case before we then get in touch with the case themselves. We'd also like to know, probably from initially the doctor, what prompted the ordering of the test, and whether there's any indication of what the source of acquisition for that person might have been, as in whether they are someone that's had known contact with a case or has had known international interstate travel. If not, we'd be thinking this might be a locally acquired case, and that would trigger some other things. And there might be some indication that comes through to us on the notification, of the Aboriginal status of this person. So, we probably see that the ordering practice was the AMS, and that might trigger some thinking around the status of that person. The other immediate priorities are, we are currently under an incident command structure, but we are downscaled. So we'd be thinking about what additional resources we might need to put on to respond to this case. And there'd be a bunch of local notifications that would occur as well, for example, to our Health Services Functional Area Coordinator, our HASFAC. And then also they would in turn communicate out to Medical Controller, the comms team, and potentially our COVID Care in the Home team.
Thank you, Kat. A very insightful response. So our last question on this slide goes to 3 different service providers. So our Public Health Response Branch, the Centre for Aboriginal Health, and to the AHMRC. So we'll start in that order, if that's okay. So when an Aboriginal case is notified, you could just describe your role, please. So the Public Health Response Branch.
Thanks, Brendan. Christine Selvey speaking. So one of our priorities is to make sure that the Centre for Aboriginal Health becomes aware of this case very early on. So we would certainly be picking up the phone to Jerry or Liz or Rachel, someone in the team, and make sure that they're aware and that they're then able to support the AMS and also the public health unit. And we would also then be looking at the resources within the public health unit to ensure that the case interview is done by a person who preferably is Aboriginal, but if not, is aware of the cultural issues that they would need to consider when doing that case interview. We'd also then be, supporting the public health unit with the resources that they might require, because we'd immediately be thinking that some of the contact tracing resources might need to be more extensive than perhaps for a non-Aboriginal person, although that's obviously a generalisation on both sides. And then, particularly if this was a remote community, less so for a regional one, I'd be having a discussion with Jerry about when should we notify the Commonwealth about this, and the additional resources that there might be available through the national National Advisory Group for COVID. That would also be a consideration. And then, of course, notifying up the line, and so the Chief Health Officer would be extremely interested, and as well as the Deputy Controllers and the Controller being Jeremy. Do you want to add anything, Jenny?
No, I think you've covered that very nicely, Christine.
Wonderful. Thank you, Christine. I think we've heard some of the role that the Centre for Aboriginal Health would play, but Jerry, would you like to elaborate beyond that?
Sure, thanks, Brendan. Our role is really that supporting type role and function, particularly to the public health response and the public health response branch. So our role is really to provide considerations where there are Aboriginal cases and contacts. And that would include some activities around advice and cultural considerations and what that looks like within a family, community and cultural context, and also thinking about things And as we learned along the way that there was real disruption to cultural activities and obligations along the way, and how we work with communities and support communities in our services to maintain connections to culture and community and family within the response. Also identifying and addressing barriers to maintaining isolation, which I know we'll probably cover off a bit later on as well in the discussion. So looking at overcrowding, feasibility and availability, accessibility of different accommodation options, also issues around food security, and as I mentioned, cultural obligations, and again, what that particularly looks like and means within a remote context as well, would need to come into any consideration in the response. Brokering relationships with key stakeholders, absolutely. Our Aboriginal Medical Services, Directors of Aboriginal Health, which we've worked very closely with over the past few months, as well as our sector and public health units. And just to note that that is in relation to where there is a case and there are close contacts, where we do have a much broader role than that in the response, and working very closely with our partners, the Aboriginal Health and Medical Research Council and AMSs on our overall response and addressing the needs of communities. And in addition to that, we have a role in the escalation of complex issues that either be up through Jeremy or Kerry, also to the Minister's Office, through CEOC, and that whole response structure, and development of policy advice as well, particularly the advice that we provided early on around travel to remote communities and looking at food security issues as well for some of our communities in more remote rural locations. Thank you.
Thank you, Jerry. I'll go to Robert Skeen over at the AHMRC. Description of your role.
Yeah, thanks, Brendan. The role of the AHMRC is mainly around supporting our members on the ground. If they need assistance with PPE, communications, networking, getting in contact with PHUs and the Centre for Aboriginal Health, anything we can do at a national level with NACHO. But yeah, they're delivering services at the front line, the coal face, so anything we can do to facilitate a smooth process, they reach out to us, we're here to help.
Thank you. We might have dropped him out. Are you still there, mate? We might move forward. Bronnie, is that all right with you?
Yep. So the PHU needs to conduct a case interview with Renee to identify her close contacts. So a close contact is considered face-to-face contact for at least 15 minutes, or being in a closed space for at least 2 hours with a person who is infectious.
And as I ask my questions, I'm just going to warn the people I ask that we're going to truncate some of the questions a little bit just for the timing. So apologies for that. But first question is to Public Health Controller Kat and Aboriginal Team Leads Christy and Kylie. In a nutshell, what information do you ask the case in an interview?
Thanks, Jeremy. I'll just kick off and then might hand over to Christy and Kylie. But broadly speaking, I guess the priorities of the case interview are to firstly look at the risk for the case themselves. So we're interested in their symptoms, their comorbidities and their vulnerabilities in terms of, their ability to isolate and anything that might compromise that. We're interested in clinical aspects, so we have sort of triage role in determining, whether people are okay to sort of manage their illness at home or whether they require a high level of care. Then the second priority of the case interview is to identify public health risks, so risks to others. So we're really interested in that person's infectious period, so 48 hours before they develop symptoms, if they did, and then all of the settings, obviously, that they visited while they were infectious, their occupation, their household circumstances, etc. And then we're also interested, as I mentioned earlier, about where they might have caught it from, so where they'd been during that 14-day incubation period and what the likely source of their infection was. But I might just hand over to Christy and Kylie for any further detail.
Okay, when the public health nurse conducts the first interview with the case, we ask for the demographic. And as Kat said, we want to find out if they're Aboriginal or not. So that's included in all of our case and contact interviews that we conduct. We want to know if they're also in an Aboriginal community and if they're also around, many other people, as well as their clinical presentation and investigating the likely source of their infection prior to the symptom onset date. For the next bit, if we know if the person is Aboriginal during the first interview and the nurse refers them to the Aboriginal cultural support team leads, and they offer follow-up for welfare and cultural support. The cultural support team leads actually conduct, they interview the case by phone, and they explore any additional support that the individual and family might need. This could be accommodation support, education and information, as well as referrals to any mental health or other wellbeing support that's identified. And then we link the case with the local Aboriginal health worker to do follow-up support on the ground until the case has recovered. So the cultural support team also have the local intel about any culturally significant events and gatherings that may be planned for the community where there may be that further risk to the community and community transmission, such as, coming up now we've got NAIDOC and there's also sorry business and school holidays and where the family are visiting from interstate. So that stuff is known locally.
Great. How do you involve the AMS either at interview or after interview?
So we wouldn't involve the AMS in the initial case interview, but as part of the follow-up health and welfare support, we find out who their GP is and encourage them to connect in with their GP. Then the AMS would be involved at that point in providing holistic and continuity of care for the case. Through our cultural support processes, we can help facilitate health access with an AMS if the case isn't connected to a GP.
Great. So on over to Chris. What are some of the cultural considerations the public health unit staff should be aware of in doing the case interview or in contacting contacts? Are you there, Chris? All good?
I apologise. There's two Chris's. I wasn't sure
Sorry.
talking to. All good. Culture, certainly, with us as local Aboriginal health workers, we'd be looking at trying to connect the staff to the family. We'd also be mindful of the family's issues with just identifying what COVID-19 is about. I mean, certainly in our community, there's still a lot of myths, I suppose, that we need to, break down. And I have Whitney online, who's an Aboriginal health practitioner and has been living in Walgett for quite a few years, a Gadurga lady, but she certainly understands culture. So may I refer the question to her, please?
Of course.
Thank you.
Hello, yes. Just around culture, probably just because we've been doing welfare checks out in the community anyway, so de-identifying the client wouldn't be an issue in Walgett, as we've been seeing in the community with doing the welfare checks. So us turning up to a client's home dressed in PPE, wouldn't be an issue. Yeah.
Great, thank you very much. I might go to Bronnie to continue the story.
Okay, so based on the interview, the PHU finds out the following information. On Wednesday morning, before developing symptoms, Renee attended her cousin's funeral and sorry business. Renee lives with her auntie and uncle and their family of 6, along with another cousin. She hasn't had close contact with anyone else. So from the interview, the PHU identifies 37 potential close contacts. So that's 9 household contacts. And 20 of the 29 other attendees at the funeral are close contacts. So that leads us into contact tracing. All close contacts must be called to be informed that they are close contacts and that they need to isolate for 14 days, monitor for symptoms, and get tested if any symptoms develop.
Wonderful, thanks, Bronnie. So our first set of questions around contact tracing go to our public health unit controller, so to Kat. So based on the activity level and staffing you have today, do you have capacity for this many contact interviews?
Thanks. So I understand the scenario is we get the result on a Saturday, and I assume we would hopefully interview that day as well. So we're talking about a weekend now. And I mean, certainly the upscale, downscale is something that we've really been kind of grappling with over the past few weeks. So we certainly surged big for the first wave, and now that cases have dropped off, we're essentially back to our core staff. On a weekend, we're now just staffing an on-call model, and so basically we have one person on call for planning, operations, comms, and a controller. And so obviously we would need to surge to meet the demand of calling 37 contacts. I thought that I'd just sort of pause here as well to mention that there's been a huge amount of work that went in during the first wave to establishing a cultural governance model. So it's great that we have these things in place already. So we have a modified incident command structure, which has the Aboriginal team as part of that incident command structure. So they sit within the incident management team. They're across, what's happening with the situation and decisions that are being made across all of the different arms of the response. And they're also informed by the Hunter New England Health Aboriginal Governance Group, which comprises representation from sort of across the district and even some colleagues across the border. And so it's great that we've got this stuff in place. There's been extensive communications to date with Aboriginal-led webinars in partnership with the Primary Health Network. There's been a range of social media videos that have been developed. There's a regular newsletter that goes out to these key partners, and a huge volume of work by Kylie and Christy that's gone into this. So, I mean, I would also ask them to elaborate on this. But as I said, we have the structures in place. They're currently not kind of upscaled, but we can put these in place at fairly short notice. So we wouldn't have that in place on a weekend, but in response to this, that would certainly trigger a big surge response, and we would probably form something like a public health response team, which would comprise, we'd engage our Aboriginal health unit, we'd involve the Aboriginal medical service. There'd be some input from the local health district as well and the medical controller. We'd probably have a lab partner on that. And then depending on the community, we might also involve representatives from, for example, the local Aboriginal Land Council. And then obviously we'd be working closely in partnership with the Ministry of Health and the Centre for Aboriginal Health.
Wonderful. Thank you, Kat. I think that explains the next couple of questions that I had around whether or not you would involve the Aboriginal Health Unit or your local Aboriginal Medical Services. So I think you've answered that really well. So I'll go to the last question for you around this, and that is, would you liaise with the Ministry for assistance around, given the number of contacts?
I think we would certainly involve the ministry in these discussions and notify up the chain of what's happening. I think, as I mentioned before, there are some quite solid structures that have been put in place at a local level. And I think the key has been sort of having these in place already so that we're not kind of starting these relationships from scratch. But certainly, we would involve the ministry and potentially call for assistance, if further things like testing clinics were planned. But I mean, I think for the contact tracing of 37 people, we could probably manage that within our existing resources that are surge. So we've got the benefit of having a number of people that have been through the AFDI program in our unit and also around the district that we could surge out to first. And then we've also got people within the Aboriginal Health Unit locally that we could use. And the local health district has also committed to providing Aboriginal clinical staff in the event that a clinical response is needed. So I think we do have some quite strong strategies in place in Hunter, New England.
Perfect. Thank you, Kat. I'm going to go to our Public Health Response Branch. So what role could Public Health Response Branch play in supporting contact tracing?
Thanks, Brendan. So this is Jetty. So we do have a close contact tracing team that are very experienced in interviewing people, and many of whom have worked in Aboriginal settings in rural and regional New South Wales as well. These people do work the weekends, and they are available and can certainly support. And so I think what we would do is develop a script for them, which is what we usually do, use experienced interviewers and have some of the support from CAR with that team while they were calling people to make sure if there were any issues that came up, that needed some additional advice, they could support that process.
Okay, thank you. My last question on this is for our Aboriginal Medical Service CEO, Christine, and also our Aboriginal Health Unit Director, Robin. So what information needs to be shared with the community, and how do you communicate this in a supportive way?
Thank you, Brendan. Communication of any description, we do have Facebook, we do have texting for personal messages. We've used, in this incident with COVID-19, we've had the advantage of the local Spectator to have a lot of positive messages around. Use the regional radio, 2 radio stations down at Berg, the local interagency, and we've also gone out to the communities, particularly Gingy and Namoi out of town, and also door knocking, as Whitney indicated earlier. We took it upon ourselves to do social welfare checks. Probably not a nice word to use, but it is what it is. And we've also assisted the pharmacy because of the social distancing. We were doing the medication delivery, so people were used to us being out and about. And I think the other issue is with the local supermarket, because again of the social distancing, people living out of town being very nervous, we were also offering our services to deliver the food from the IGA. So just being out and about, I think if you have that baseline in the beginning, it just makes life easier to communicate, doesn't it?
It sure does. Thank you, Christine. Robin, have you anything to add to that?
Just one more thing from while it's Wayne here. We also, just adding to what Christine mentioned, we also did hand washing demonstrations to the schools, to the kids, so they learned how to correctly wash their hands and when they should be washing their hands and stuff like that. So that went really well.
Amazing, thank you. To Robin?
Thanks, Brendan. Thanks, Chris, out at Walgett. For the Mid-North Coast, a range of what Chris has indicated has been coordinated with our partners. Individually, they've been undertaking those as well as the local health district and together. Some of the other things is our key stakeholders, such as our decision-making groups, so through your Tribal Wave, Three Rivers, Muddy Parky, etc. For Mid-North Coast, I would certainly touch base with our zone local land council rep, Peter Smith, and just touch base. Our Aboriginal NGOs, and in particular in the communities along the Mid-North Coast, there's an Aboriginal interagency in each community, so quite a large network to assist to promote the messaging. So that's probably all I just add at the moment from what's been said, Brendan.
Wonderful, thank you. I'll hand to Bronnie now.
Okay, so the public health team completes the contact tracing for Renee's close contacts, and several have reported symptoms, including one who reports mild symptoms that predate the funeral. This suggests to the PHU that there could be more virus circulating in the community and that increased testing in the wider community may be needed.
So, question to Kat and Robin and Chris. How do you formulate the most appropriate strategy to rapidly scale up testing in the community?
Thanks, Jeremy. I'll kick off. I think it really depends on the community, whether that's a well-defined community and also the size. So it would really depend on the situation. We'd also look at what's already in place. So as you know, everything's been about testing lately. And so there's a range of different models, as Roy highlighted before. So we've got obviously our local health district clinics. There's the PHN-led community respiratory clinics. There's some mobile pop-up testing that's happening. There's the Gene Expert, and then there's obviously all the private sector as well. We've had quite a bit of success with setting up some drive-through clinics through our local health district, and that seems to be a model that's had high acceptability and has also been quite good to rapidly implement in certain locations. So that might be an approach that we'd be considering through the LHD.
Thanks, Kat. Robin, what are your thoughts?
Yeah, so rapidly, the first thing once Paul Colburn walked down the hallway to my office to let me know, or called me on the weekend, would be recommending that we instigate a meeting immediately with our Aboriginal Medical Service partner of that community. Involved would be obviously Paul, the Director of Public Health, our AMS CEO, HASPAC Coordinator for the local health district, the key senior Aboriginal manager in health for the region, the PHN, and the hospital management for that immediate meeting, so that we can agree on our response plan, team, etc. going forward. But it's really important that our AMSs are at that very first meeting when we collectively respond. I'll just stop there in conscious of time, yeah.
Thanks, Robin, and a nice segue into Chris. What are your thoughts from an AMS point of view?
Good on you, thank you. I was waiting for that. About communication.
About sort of how to set up a strategy for increasing testing in the community.
I suppose we attend the LEMC meetings every, not only the Gadooga ones, the Walgett covers Colorinabri, and we also attend the Brewarrina LEMC. So that in itself enables us through the action plans to implement what needs to be done when the occasion rises.
Great. Well, thanks all. And who would lead the organisation of getting extra testing sites up? Would that be the Public Health Unit, Kat?
Yeah, Christy and Kylie and I were trying to think this through, and we thought probably ultimately it would sit with the Public Health Controller as sort of the coordinator, but obviously there would be liaison and partnership with the people on the ground.
Great. And back to you, Robin. Is there anything else that the Aboriginal health units can do to support the communication of the increased need for testing in the community?
Yeah, look, I think just being on the front foot and communication established before this scenario. So have our relationships been established with our Aboriginal Medical Services and the Public Health Unit, because as you're aware, there's a range of other things that goes on besides COVID, and that our relations should already be established with our AMSs. There's obviously a workforce, the ability for the Aboriginal Health Unit to advise the Public Health Unit on the workforce, the surge plan and surge staff that we have designated at the moment, but also that what support workforce needs may be, for the Public Health Units also to have an appreciation and understanding of the community and the resources that sit in the community, or the resources that may sit with an AMS. So that would be my initial comments, Jeremy. Hope I answered the question there.
Perfectly. Thanks, Robin. Now back to narrator Bronnie. The next slide.
So supporting the community. So Uncle Robbie was the only member of his household who attended the funeral and is a close contact. He's worried that staying at home could be a risk to the rest of his family. However, he doesn't have anywhere else he can stay for his 14 days of self-isolation.
Wonderful, thanks, Bronnie. So my question, and conscious of time as well, so if we could put a couple of these. So our Public Health Unit Aboriginal Team Leads, Centre for Aboriginal Health and the AHMRC. So what accommodation options are available to Uncle Robbie and his family? In particular, who organises the accommodation and who pays, etc.
Okay, well, the Public Health Unit actually organises the accommodation. So Hunter New England has an alternate accommodation process for hospitalised COVID cases and any contact. Home isolation cases contacts may be offered alternate, and if it's assessed that true isolation can't be achieved, then we find out about the challenges of isolating safely on case interview and discuss with them the alternate accommodation. A referral is made to the accommodation coordinator who confirms it, and they pay for it. and the local health district organises all that from their end. In addition to this, we've built into our own cultural processes a way of identifying other accommodation if the case resides in a town where there's limited accommodation options. And some of these alternate accommodations have been vacant social housing, teacher housing, health clinics and other like public buildings or buildings that belong to the Aboriginal community. Hospital and KIF patients should have their accommodation and transport needs assessed and organised by hospital and KIF staff.
Perfect, thank you. Jerry or Robert, anything to add to that?
Thanks, Brendan. I'll just quickly add that there is a centrally managed booking service as well for emergency accommodation needs for cases or symptomatic contacts, which is available through the approved New South Wales Government supplier, FCM Travel Solutions, and that is billed to the local health districts. And that information is being distributed out to CEs, but it's also available on PopNet. And the team internally here in the Ministry have also put together a flow chart which looks at the transport and accommodation options, which is another, I suppose, resource or tool that is available for our districts when considering accommodation options, and that is also on PopNet. But Jeremy or Bronnie, did you want to add anything to the amazing flow chart that you've pulled together?
That's okay, yeah.
Okay, thanks.
Wonderful. Robert, anything for you?
Yeah, just quickly. We do have members who sourced and worked with their own contacts. Studies online. They sourced local accommodation to make sure that the community did have an alternative to go. We also worked with our local members to develop local resources to provide information around social isolation, if there was a need for people to be isolated in the community. And we did work with a range of experts, including Steve Crooks and Kylie and our own cultural group, the AHMRC, developed as resources as well. So it's made it, high level advocacy and relationship roles as well.
Thanks, Robert. It was a little bit difficult to hear. We're just getting a funny sort of electronic sound.
Yes, sorry.
No, that's okay. I
Sorry.
think everyone picked up on it. Just in addition to the first question I've asked, is that sometimes our Aboriginal families have issues with being separated due to past historical trauma, and also in these types of events, people want to stay connected. In the event that we do have challenges with people being separated, how do we work with families to decide what the best option is for them?
It's Chris talk from a public health unit perspective. So we'll explore with families about what would be most achievable for them and what could make sense for them. For example, either moving one member out of the house and separating them into an alternate accommodation. We've been told through our local community action plans through the LMNCs that elders would prefer to stay at home and that it might be better for others to relocate to alternative accommodation. So it's just having that conversation engagement with the families around how that should be done. And we know that high-risk family adult contacts would be also encouraged to relocate. So some of the things to consider here is if they've got other family members to help support them, taking into consideration that it can be lonely, and what would be the impact of relocating, rather than staying together because of distance and travel and extra burden on other family members. Thanks, Brendan.
Thank you. Jerry, anything to add to that?
No, not really. And I probably should have just said before too, and just building on what our colleagues in Hunter and Christine, also Walgett, said, that around the community action plans, where we know that there has been good participation and engagement from different community groups and services around preferences, I guess, around potential relocation of cases and contacts, preferred accommodation options, and that, as we've just said, discussing the importance of engaging families in those conversations and considering their preferences and how that is embedded and integrated into our response around. Yep. Sorry, Brendan, that's all.
Absolutely wonderful. And I think you've touched on what would have been my last question, just around any other health or social supports that should be considered for Robbie, his family during the self-isolation. So I might throw back to Bronnie to take us to the next part.
Yeah. So just in the interest of time, we're just going to skip our next slide. So if you're listening on without seeing the screen, we're on to the next slide that says scenario ends. Okay, so no other cases are detected in the community. Despite the pop-up clinic being very well attended. The other non-household close contacts of Renee were released released from their self-isolation 14 days after their last contact with Renee. And Renee's symptoms resolved 2 weeks after the onset of her illness. So her household remains in isolation for a further 14 days, and fortunately no one else developed symptoms, so the whole household is able to be released from isolation. Okay.
So that brings us to the end of the scenario. So thanks to everyone for playing and for Bronnie for reading so well. Greatly appreciate everyone's contributions. I'll now hand over to Steve and Jamie to lead us through a short debrief. Often these are the kind of important sessions to kind of reflect on what we might learn from these. So Steve and Jamie.
Jamie, I'll start off if that's okay.
Yeah, buddy.
Look, I think we've heard a terrific exposition of what preparation has gone into anticipating what might happen if we get an outbreak like this. But I guess the purpose of a debrief is to really hear from people about how well prepared they feel they are and what else might be done differently. And I've got some questions myself. Jamie, did you have anything to add as to what people should be coming forward with? We've got 28 people online. This is a really significant event, I think, because it's the first opportunity we've had to share information about our level of preparedness. Jamie, do you have anything else you want to say at this stage?
Yeah, mate. From the discussion and the questions being raised and the responses from all people, from whether it's the LHD, the PHU, our state bodies and the AMS's, understanding of what needs to occur. But one of the things I would ask is it a coordinated approach to it? So all of our sector, all of our services know how to respond. Some of the takings from me is about how do we coordinate that, given that we've gone through a pandemic, but preparation for what could come or other pandemics that may come.
Would anyone like to comment upon Jamie's question about coordination? I've got a couple of other headings that I'd like to ask him quickly about, but if we go to coordination of responses first, does anyone like to volunteer any comments or critiques of what we've heard? I mean, I think we've heard some good examples of in the Hunter of how well things are likely to be coordinated, but others?
It's Jeremy. I guess from a state point of view, the Chief Health Officer, the Secretary of the Department of Health is the ultimate controller, and then the Chief Health Officer is kind of the responsible for public health coordination, and then that's delegated down to the FEOC, the Public Health Emergency Operations Centre, which then works across the public health response with public health units in each LHD. But then beside that is the SHEOC, or the State Health Emergency Operations Centre, which coordinates with LHDs, the clinical services. So it's kind of a helicopter view, if you like, Steve.
Okay. Look, I had some questions about. Well, I'd like to ask people on the teleconference. I've sort of divided it into a few headings. We heard firstly about testing and the mechanics of testing and how that has to happen rapidly in the community. Does anyone on the teleconference have any questions or critiques or concerns about how testing might happen in the event of a potential outbreak? No response? Do you think, Roy, perhaps it's well known, particularly in rural New South Wales, how this might happen? I mean, are you confident that it works in the most remote places in New South Wales?
Yeah, so that's something that we need to have a discussion we need to have with the AMS and the New South Wales Health Pathology and private pathology providers if what the options are. I think it's, you know, the key priority for organising testing in remote and regional areas is turnaround times. And so we'd have to look at what options are available that provides the shortest turnaround time for results. So that requires discussions with the local, with the public, with health pathology to see if they have capacity to provide the testing and also the staffing. And secondly, whether the local laboratory has capacity to perform the tests, because if there is an increase in number of tests being done, it impacts on their ability to do other tests. And so I have to look at what options are available if the local laboratory can't do the tests as well. So it'll be a consultation with various stakeholders to look at what options are available.
Jamie, did you have any comment?
No, mate. Look, what we've learned as an Aboriginal medical service is, and I think Robin made some comment earlier about the AMS need to be engaged from the get-go. Our connection with our clients through whether it's a pandemic or the health, if we're not, a lot of the responsibilities fall back to us. So us being at the table from the get-go is critical for that ongoing maintenance, monitoring and support. I heard some people say towards the latter ends of the conversation around the psychological or counselling support that has to be in play because not only impacts the individual, the connection with their families in that town, but across the region can create some angst and anxiety if we don't have a very responsive function here to our community. So the AMS play a critical role in that. And I think, and I know that we need to be engaged at the initial stage, not after.
Yeah, I mean, my experience with I work in the Aboriginal Medical Service here in Western Sydney is that people were capable of performing small miracles in terms of contacting people at critical times. I just did wonder, though, what people thought about the difficulty of contacting people who are close contacts of a case and did what was described ring true for people. Any comments? Are we all confident that the 37 people that we need to contact on a Saturday morning could be contacted easily? It wouldn't ring true with my experience of working in the AMS. That's all I'm saying. And I just wonder, I mean, what you were saying, Jamie, is that there are many ways to do this. I wonder if anyone else has some comments or questions about that.
Hi, Steve, it's Kylie from Tamworth. With a case, as you know, it's been their contact with that person within the last 48 hours. So we'd be really encouraging the case to help make those initial phone calls first before the public health unit had to. With all the community action plans, one of the things we've really tried to encourage the community is that, you know, the community needs some agreement about letting each other know when there are positive cases, because as you know, we can't breach confidentiality or privacy, so we don't make a big announcement that there are cases. We'd really be encouraging the community and, you know, and seeing them as champions and wanting to really look after the community. So it's important to get that out early by the cases or close contacts. As we say, we won't ever out them. It'll be sort of, you know, their family members or each other who do that. But that would certainly make it much easier, is you let the community drive that or the case. You know, you really get them on side very early and you know, make sure that they know how vital and critical it is, you know, to do the contact tracing very early. And you know, you can talk through how important that is. And like we said, you make them know that they're really stopping community, you know, transmission by doing this. A lot of the language and a lot of the interviewing is very, you know, it's very colonial and it's very interrogative. The language is, you know, is terrible for Aboriginal people. And that's one of the things we wanted to build into the cultural support yarns, really, we're calling them. So it's not that sort of interviewing, interrogating language. And because they don't have to repeat the shared lived experiences with Aboriginal people, there's a lot of stuff that we can actually uncover quite early in that contact tracing as well. And that, that they'll probably tell other Aboriginal people. And there's lots of common phrases and language that we use that we know what we mean without actually having to say it or explain it. So whilst we understand that many people have worked in Aboriginal AMSs and settings before, that shared lived experience and that trust we already have with each other means that, we can find out some key barriers and challenges very early to help people, maintain isolation and quarantine, especially now that the rest of the community has actually opened up. It's actually going to be harder for that to happen now, and those mental and social supports are really key to anybody in home quarantine or home isolation now.
Another observation that I would make here is the legalities of a public health order and whether our communities are aware of it, whether our services are aware of it, and how do we prepare that education information to our community. So that would assist us in being able to engage with our communities. Shame will always play a factor in our engagement with our people. So how do we have a response that covers, from a governance perspective, the legalities of the AMS being involved in this and what role, function they play? If it's a consistent message, and I think we've learnt, especially at Orange AMS, that there are inconsistent messages out there that could be a deterrent for what we're trying to do. So, which goes back to the coordination, so that we have a similar message, whether you're in Burke, Walgett, Tamworth or Orange, that we are presenting a similar message and approach to a pandemic and what our roles and functions are. People are transient, naturally, but I think it's critical that we have that from a board perspective. They would want to know the legalities of that, succession at our local services, who's a contact. I heard somebody say that earlier about contacting CEOs, but is the CEO the right person to contact? Should be looking at as a clinical approach and having that knowledge and understanding from a management perspective, but who should be the go-to, and especially critical is a succession, so that we're not putting pressure on just one individual to respond if there's an outbreak in our community.
Okay. Look, I have two more questions quickly. I know we're out of time. And the first really relates to what Jamie's just said, and that's really about compliance with home isolation and what difficulties that people on the panel think might occur in terms of achieving compliance with home isolation in communities. And the second really was about how to deal with the high levels of comorbidity in the community. It obviously will be an issue in terms of assessing risks and isolating people and finding accommodation. And of course, it's a reality that lots of people in community do have serious comorbidities. And I'd just like to put those two questions to the gathered here. Any comments?
Stephen, it's Mary Kay. I think all the questions you've raised need to be answered, and it might be a suggestion that in order for us to know if we are prepared, why don't we run something through its paces, run a pilot or a test through its paces to see how prepared we are for a rural outbreak, and just do a very controlled scenario where we can see what are the local emergency services available, if there are comorbidities that need to be addressed immediately, what are the turnaround times in certain areas for getting results back, and what type of testing is feasible to be done in a rural area where there may not be a lot of on-the-ground support to the community. So running a pilot or having some type of a controlled test might be a good way to see how prepared we are for these sort of scenarios.
Okay, well that's all I had.
Thanks very much.
And Jerry, Look, I thought this was a terrific session. I've learned a lot about preparedness in other places, and and I think that last suggestion is really a great idea. So back to you.
Thanks very much, Steve and Jamie. So just to wrap up, thank you. Just wanted to acknowledge the hard work of the panellists, the Centre for Aboriginal Health, HMRC and Hunter New England Public Health Unit for helping developing the scenarios, and also Jamie and Steve for thinking through it and working on that debrief. And Brendan, thank you very much to you for co-convening with me. Over to you.
It's a pleasure. Thanks.
So we might wrap it up there, and thanks very much all. We'll sign off. Bye-bye.
Bye now.
Thank you. Bye.
Bye.
Well done, team.